formal presentation
Okay.
for YouTube audience.
What, does it follow you?
Yes, now when we start the transmission, we are live, and everybody that connects to YouTube.
Where's the camera pointed?
Here. Laura is checking.
You move it?
Yes.
You move it?
It's okay now.
It's okay? Okay. It's alive?
Yes.
Okay. Good morning. It's indeed a great honor and pleasure to be here today. To extend a warm welcome to our distinguished guest and esteemed colleague, Professor Nathaniel Simon Triester. He's professor at Harvard School of Dental Medicine and chief of Department of Surgery, Division of Oral Medicine and Dentistry at Brigham and Women Hospital in Boston. Professor Triester is not just a distinguished academic, he is a global leader in the field of oral medicine. His presence here today opens exciting possibilities for collaborative research projects and other academic activities between our institutions. We are privileged to have him here with us at URGS for the next 2 weeks. I would like to thank CAPS for the support, and all of this would not be possible without the collective efforts of 3 graduate programs of URGS. So thanks Dr. Cassiano Rising and Fabrício Colares on behalf of graduate program in dentistry. Thank to Clécio da Silva on behalf of graduate program in child and adolescent health, and Dr. Jonas Sott and Dr. Maria Rigato on behalf of graduate program in medicine, medical science. The lecture of this morning is entitled Intralesional Corticosteroid Therapy for Inflammatory Oral Ulcers. Nat, once again, thank you very much for being here and sharing your knowledge with us. And go ahead, the stage is yours. Thank you so much.
Thank you. Let's use this. Yep. 2 minutes. All right, very good. All right, can everyone hear okay? I'm going to try and keep this in one place and not move around. Thank you so much for the nice introduction. Thank you for the nice welcome. I know you're happy that I'm here, but I may be happier to be here than all of you combined, and you don't realize that. So, as I've told Mano and many of my friends here in Brazil, I have such deep love and appreciation for my friends and colleagues here. The approach to life and the culture. I don't remember the first year I came, but it's been over 10 years. And with multiple visits, every time my friends make jokes and I become more resilient. And I hope I can actually speak the language well within some period of time. It's going to take years, I know. But I'm really happy to be here. So, and as Dr. Martin said, don't be shy. I'm happy to talk to you, answer questions, convince you why you should or shouldn't go into oral medicine, all sorts of things like that. So I'm happy to. This lecture today, how long do we have on Manuel? You have to remind me, how long do we have scheduled for this?
1 year, 1 hour and
1
1 year.
We
1
have
hour and 1 hour and a half.
Okay, very good, very good. I tend to go kind of slow when I'm with an audience that maybe doesn't speak English as first language. And there's a lot of information in here, so I'm going to try and be careful and just keep track of time. Because some of the things that maybe I don't need to go into so much detail, we have time to talk about when we talk about papers later this afternoon, which I think some of you will be here for. And just a little bit of background on this lecture. Not that every lecture needs a long, detailed introduction, but this is intralesional steroid therapy is something that is a really important piece of sort of my armamentarium when I'm treating patients with inflammatory conditions in the mouth. It was something that I learned about as a pre-doctoral student when I was at the University of Pennsylvania. Lots of experience there with intralesional steroid therapy, so I would learn about it. When I came up to Boston, also Immediately, we were treating patients with intralesional steroid therapy. I was becoming more and more comfortable with it. But as a dental student and also as a graduate student resident, I don't know that I ever had any formal education or training in intralesional steroid therapy other than here's what we do, here's how we do it. Oh, now we have a patient, let's do intralesional steroid, and I think I'm going to give them this much. And that was just sort of the way it was. And I think that even in that context, I was able to gain a lot of expertise and just clinical expertise in managing patients. But it was only a few years ago, 2 years maybe, less than 2 years ago, and I was giving a talk, I was invited to give a talk to a colleague, with my colleague in her group in Indonesia, in Jakarta. And it was for a sort of a big general dental meeting. And I was going to give, a big invited lecture. And she asked me specifically, she said, we want to learn about this. We don't know anything about it. We've never done it. Nobody in Indonesia in oral medicine is doing intralesional steroid therapy. We want you to talk about it. And I said, okay, that sounds like a good topic. And then I thought to myself, I've never even had a single slide other than talking about treating some condition and then having a bullet saying intralesional steroid therapy is effective. So it forced me to do really fun, academic, intellectual, scholarly sort of digging, so to speak. And the presentation I have today and the papers we'll talk about later today, I think is probably right now the best distillation of knowledge and information about this treatment, because I've never seen it anywhere else. I've never seen a paper on this. It's gotten me excited about some other projects and some things to write about and publish. But I hope you find it interesting, because it was really fun putting together. And like so many things in medicine, and we were talking I was talking with somebody yesterday about my background. I'm a history major, and I find, we do undergraduate then dental school, so you almost have two educations when you go into dental school in the United States. But I love when there's a story to what we do, and some things have a much richer and longer and interesting story than others, and this one I think is a really interesting story. So, Emano, you have to tell me, because how different the audience is from group to group, but I just made this slide for another presentation. I gotta advance my slide. Whoop, hold on. Good. You'll have to tell me if I should include this slide for multiple lectures, or if it will become the same thing over and over. But just to give everyone some context, I work in Boston. I'm in the Brigham and Women's Hospital, is a clinic there. I have a clinic at the Dana-Farber Cancer Institute, so a completely oncology-focused clinic. None of these clinics, the clinic at Brigham and Women's, we do a very, very small amount of dentistry. And it's our residents that are primarily doing that. So if they need my help, I come and I help with extractions. But for me, nobody comes to the hospital or the cancer center for a visit with Dr. Triester for a dental visit. Everything is medicine. I see a pediatric clinic at Children's Hospital, and now for 6 months, I've been going to Dartmouth-Hitchcock Medical Center, which is up in New Hampshire, which is about 3 hours from Boston, so a very remote area. When you go north of Boston, it becomes very, very quiet and very rural, with big mountain ranges in the states going up towards the Canadian border. So just a little bit of that context. I think all of you sort of know this story well, but in oral medicine, we're going to talk about a treatment today. But before we can talk about treatment, we have to think about who are the patients, where are the patients coming from, how do we evaluate a patient, how do we even determine that intralesional steroid therapy is maybe something we should even be considering. And we'll talk about a number of different conditions today that we treat where, for example, and I can't use a pointer here, but for example, where a patient may be referred from GI, from gastrointestinal. Patient may, I mean on the screen, I can't use a pointer. Don't
If you
forward.
want.
No, it's fine. I know there's a pointer here. No worries. Well, we'll talk about some oncology conditions. We'll talk about rheumatologic conditions. I know there's going to be a whole other talk just on rheumatology. You can see how all these patients may come into my practice, and then in evaluation, I may consider a specific treatment. Obviously, again, you need to make a good diagnosis. This is obvious for everyone here. You know how to evaluate a patient, but you know that you need to use a good light source. I don't know if this ever happens to any of the faculty in this room, but sometimes when I'm seeing a patient with my residents, they come and tell me what they've seen. They've examined the patient, and I go into the operatory, and I always use a mirror to retract, to look. You know, I think you need something more than just your fingers, and the mirror is still in the packaging. I sort of give a little bit of a look. I don't say anything. I take the mirror out and I do my exam, of course. So, again, evaluating the patient, very important. You can't treat a lesion. You have to treat a diagnosis. So, for example, sorry, I'm not going to get good at this. So this was the first slide I was saying. I thought it had advanced. For examination, you can see the mirror being used in a few different ways here, but I would just argue that you should always be using a mirror when you do an examination. And then for this slide, the idea here is that, again, you can't just treat ulceration, right? There has to be a diagnosis. All of these patients are in pain. They all have ulceration. They all have ulceration within the buccal labial mucosa. But the diagnosis for each of these is completely different. The treatment is completely different. And for the purposes of the lecture today, I'm not going to spend time talking about what these diagnoses are, so you can ask me another time. But I would argue in all four of these, I would not use intralesional steroid therapy in any case, based on the clinical scenario and based on the diagnosis. In at least two cases, it would be totally inappropriate. Similarly, if we're looking at white lesions, again, these are all white lesions in the mouth, but if we describe them and we think about them with more specificity, they look very different. Some of them maybe we can make a diagnosis just from looking, others maybe not. But again, we can't just say that something's white and make an assumption based on that. So the conditions that we'll talk about today for which we would consider using intralesional steroid therapy are all mucosal immune-mediated conditions. And as you know, you're all studying this or thinking about studying stomatology and oral medicine. It's an amazing clinical spectrum. I think it's what makes us love the field, and that's just mucosal disease, forgetting about all the other conditions that we see and manage. And some of these conditions may be specific to the mouth, or it may be something that's with a multi-system, multi-site condition, where the mouth is one or maybe the most important part of involvement. Patients may have pain. They oftentimes have sensitivity. So they don't have pain necessarily all the time, but with eating or drinking, something functional can be very uncomfortable. Sometimes the problem may not actually be pain at all. It may be disfigurement, because a patient with orofacial granulomatosis, they have a very large swollen lip. It's not painful, but they're not happy about it, so it's something that they want to have treated. So it can have an impact on quality of life in a number of different ways, or potentially actual overall health. The conditions we'll talk about, lichen planus, aphthous stomatitis, the autoimmune vesicular bullous diseases, primarily mucous membrane pemphigoid and pemphigus vulgaris, orofacial granulomatosis, and traumatic ulcerative granuloma. There may be a few other conditions you might consider, but I think this accounts for the vast majority. And these conditions are all managed, if they require management, they're all managed with some type of immunomodulatory therapy, oftentimes steroids. And as we know from an oral medicine standpoint, we can use steroids systemically, we can use steroids topically, and we can use steroids intralesionally. And I came up with this slide when I was preparing this talk for the talk in Indonesia, again, to try and think of sort of the concepts. And so if you see the 3 panels on the bottom, you think about the mouth or the condition that you're treating as if it's a natural disaster. And I think a fire is a good one because we think inflammation, fire, sort of heat. And so maybe you're at the point where you smell some smoke. It's, maybe something just needs to get addressed very quickly, and the fire is never gonna come back again. I don't show that here. That's sort of like an earlier one. Maybe you're dealing with, the full blown out fire, and you can't go in and put a topical treatment because you're going to burn your hand, right? You need to just throw something big to put the fire out. But now you have a spot fire, and maybe at that point you can go in and do something like a topical treatment or maybe intralesional treatment. And then I think the really interesting condition is the one all the way to the end, because for many chronic conditions, that's really what we treat. After the first month, we put the fire out, but now I'm still seeing this patient 20 years later. And there's a little, explosion here and there, but for the most part, you're just managing your condition. But that management may require a combination of treatments. So here, these are not all necessarily, fires, forest fires, but here, 4 examples of patients, all with very painful or symptomatic oral mucosal inflammatory conditions with ulceration. And these patients need or want some sort of intervention to help make themselves feel better. Similarly here, we have patient in the upper with pemphigus vulgaris, painful open sort of erosion on the lip. In the lower panel, a patient with mucous membrane pemphigoid. Again, far more common than pemphigus, but not a very common condition, but I'm sure a condition you all see here in the clinics. And then orofacial granulomatosis. Some of these patients have inflammatory bowel disease, so this is a manifestation of a systemic disease, or patient with a lip swelling is just orofacial granulomatosis with no other systemic features. And then finally, in a really interesting condition, traumatic ulcerative granuloma, or TUGSI, traumatic ulcerative granuloma with stromal eosinophilia. I know less about pathology than most of you in this room who have studied pathology, but I have obviously my pathology basis. This is a very interesting condition we'll talk about a few times during this talk. So again, we're going to focus on one specific treatment, but I think it's important to think about the basic concepts of therapeutics and how we approach treating a patient. And again, I emphasize this at the beginning, you have to have the correct diagnosis. We never treat an ulcer, we treat a diagnosis. You should have some sort of defined treatment objectives. Is your goal to make the condition go away? If that's your goal, it may not be achievable. Is your goal to reduce symptoms? If that's your goal, how many ways do you have to potentially achieve that? And is one better than the other? So you have to think about what's the goal. At the end of the day, you have, for example, a patient with cancer diagnosis. In most cases, the goal is to extend life. But maybe that's not always the goal. In some cases, the goal is to make the remainder of life as comfortable as possible, or to avoid a toxicity, and therefore, so again, it's not always the simplest of answers of what is the goal of treatment. I would argue that for oral medicine and stomatology, whenever possible, an intensive localized therapy is our best option because we don't have to give something systemically and we don't have to potentially take the risk of systemic side effects. But it's not always going to be the case that we can do this, and there will be times when we have to use systemic treatment. There's also conditions for which systemic treatment will just be more effective. And knowing all these little nuances is what helps us makes us specialists and allows us to provide, highly specialized care. For any treatment, even a really simple topical treatment, you have to be able to anticipate what side effects may develop. Not that you know it's going to happen, but it could happen. You want to counsel the patient about that. And just, anything that they should know about, where you could anticipate that they would have a question. So you want to give education, instructions. For any patient who has a new diagnosis for a condition in our clinic, we give them an information sheet that talks about the condition, but then a big part of the sheet, the informational sheet, talks about the treatment and how they'll use various, for example, topical therapy. And of course, for any treatment, you have to think about cost. At least in the United States, insurance can be very complicated. Even if, the two of us have the exact same insurance from the same company, let's just say, this water bottle insures us, she may have a different plan so that she can get a medication, and yet when I try to get it, it's more difficult. So it's really complicated in the United States, probably far more complicated than it needs to be, and maybe it's just as complicated here. But knowing your environment, knowing how you work, knowing that, I really want to prescribe this, but that medication costs 100 times this medication. And if I try prescribing that medication first, the insurance company probably is going to say, you need to have tried this first, and it's going to create all this paperwork, and maybe it would be better if we just start with that option. So things to think about. So here are some sort of examples of conditions being treated. This is a patient with lichen planus, lichenoid inflammation. It's actually a patient with graft versus host disease. And they've had no treatment. They're symptomatic. We start them on dexamethasone solution, rinsing 3-4 times a day. They come back in a month, and symptomatically, they report that things are much better. 60-70% better, and clinically you can see how much of a resolution there's been in the overall inflammation, right? Because the white changes are due to inflammation. This is a patient with lichen planus, really severe lichen planus in the mouth, but also all over the skin and affecting the vaginal mucosa. And this is a patient who had seen many doctors over a number of months before seeing me, but never had a diagnosis and was never treated appropriately and was really having a tough time. So when I saw her, she could barely go to the bathroom because it was so uncomfortable for her to even sit down, let alone to, deal with the pain afterwards. So as the oral medicine specialist, it was basically my obligation to put her on systemic steroid therapy. I could have focused on the mouth alone, but it really wouldn't have made her better. I could start her on a topical treatment also, but I can also start the topical treatment later, depending on how important I think it is. So in this case, an example of systemic. And then here's an example of a patient with really severe lichenoid inflammation. This is a patient with graft versus host disease in the mouth. They're on systemic immunosuppression, as many or most of my patients who have graft versus host disease, because maybe they have it in the skin, they have it in the eyes, it affects their lungs. They need to be on a long-term either steroid course, or they're on a long-term tacrolimus or other agents. This patient is on very intensive highly specialized topical treatment for the mouth. So they're on a compounded, very high potency topical steroid. And despite the systemic therapy, despite the topical therapy, they still have this very intensive area of ulceration. It's become fibrotic, it's painful, and that's the area that I'm treating with intralesional steroid therapy. So it's not necessarily the whole mouth needs to be treated this way, but I can target a very specific area. So, to the best of my understanding, in really digging through the literature, and in particular leaning on some of the references used in the dermatology literature, this seems to be more or less, like I say, ground zero for the literature in intralesional steroid therapy in medicine. And it's a really cool, really simple paper that I think we're going to talk about later this afternoon. It's from 1952. Have any of you read a medical or dental journal paper from the 1950s before? Probably not. Even if we asked you if you've read papers from the 1980s, you probably think that's really old. But I'm going to have references from the 1980s, 1990s, because there's really important things that were done and reported then that haven't been reported since. And if you don't go back 20 or 30 years, you don't find it. This paper from 1952, I'll simplify it just so I keep the pace of the lecture going. This was a group working with a steroid suspension compound from, I think, Merck. Yeah, from Merck and Company, so big pharma, but back in the 1950s, was obviously everything was much smaller. What the relationship, this was a group in, I forget what university, University of Cincinnati. Had some sort of relationship or consulting, or we have an arrangement to do research with this compound. And I have to be honest, I don't know when patch testing, allergy patch testing, when you put to see if you react to a metal, or I don't know when that first started, but I can't imagine that it was a very advanced field by 1952. But at this point, they're already working with patch testing kit. And in 13 patients, they decided to do an experiment, and they're going to patch test these people, but then we're going to inject the steroid and see if that affects or attenuates or diminishes the patch testing responses. And they found that in the majority, like 11 of 13, they actually had a really profound effect. And that basically demonstrated that if you injected steroid locally, you could actually have a localized effect on the inflammation. From this paper in 1981, this summarizes at the time, and I don't know that it's changed, all the various formulations of injectable steroids available. And I note here with the STAR catalog, which is available even back in 1981 at either 40 or 10 milligrams per milliliter, is the most widely and routinely used in the skin, in the mouth, in the eye, in the joints. I'm not a pharmacologist. I don't want to tell you that I know exactly why it's better than all the others. But this is typically, when it's available throughout the world, the standard sort of used intralesional. And 40 versus 10 is just the concentration. And so some of the studies we talk about, you'll see that I'll have some comments about 10 versus 40. So I would argue that when we're treating in the mouth, it's always best to use 40, because it just means that whatever the dose is that you want to deliver, you can give a fourth of the volume if you were using 10, if that makes sense. So you're giving the exact same amount. So either I can make somebody's lip swell out to here, giving a dose, or I can puff it out to here a little bit. Or same thing, you can inject into somebody's tongue, not even usually very painful, but do you want to give 4 times the amount or a quarter of the amount? And then this is a paper from 1961. So imagine this is only 9 years after an experimental group, testing. So in only 9 years, which I think is amazing, you have this paper. It's treatment of a variety of dermatoses with intralesional injections of triamcinolone diacetate. One author, Forest Hills, New York, and talks about triamcinolone and a concentration was injected, describes the needle, talks about giving it very superficially or even intradermally. We can't do the intramucosal, I think it's too fine. Talks about wiping the area first, spraying it, so he gives like a little bit of a topical anesthetic. Notes that patients have no discomfort. Talks about there being like a little bit of a reaction in the skin afterwards that goes away within hours or a few days. Talks about how much this person gave, and then is very specific that no other local treatments were given in describing this series of patients. Again, just a really nice, very simple, but incredibly informative paper. And again, the fact that this is less than 10 years from that first paper, I think is really neat. So, this is really just to go over the basics. For any of you who have experience, I know this is really obvious, but I already talked about the difference between 10 and 40. Again, the idea is this is giving a, depending on how large, but an intensive dose very locally, typically for either a non-healing ulcer. Again, we have a diagnosis, but it's just refractory ulceration, or other type of tissue inflammation like orofacial granulomatosis, or even just areas that are difficult to treat topically, or for the patient, it's difficult for them to maintain a topical regimen. And interestingly, only in the last few years, I've had a growing number of patients, and they're very small, just a handful, but a growing number of patients, for example, with bilateral buccal involvement lichen planus, who, they try to keep up with the regimen, it's only working so well. At some point we have the discussion, I said, we haven't done it, we could try intralesional and see how you do, because for some patients it may give a few months of relief for something like lichen planus, like where it's, again, you're not putting out the forest fire, but you're just sort of dealing with the smoldering. And I have some patients that, even without ulcers, but they're symptomatic, red and white changes. I do bilateral intralesional, and they come every 3 to 4 months, and they're perfect for that amount of time without any localized treatment. I think it's probably a pretty reasonable treatment, but it's not what I'm going to offer for most patients. The procedure is really simple. So I start with a question, local anesthetic, and my answer to the question, at least for me personally, is you do not need to use a local anesthetic. We can talk a little bit more about why shortly, but imagine that you're going to inject into the lip or the tongue, and I can tell you that we use a 27 gauge needle. Patients don't even usually feel it. There's nothing noxious about the triamcinolone. So if you've ever had injections or infusion, and you feel like there's like a burn or fire, it's nothing like that. It's very neutral. And depending on, unless you're trying to inject, for example, into the hard palatal mucosa, where there's no space, lip, tongue, there's plenty of space, buccal mucosa, there's no pressure that builds up, it's really not a painful condition. But also, you can't make the injection less painful unless you give anesthesia first, because it's simultaneous. So if you give the injection with local anesthetic, it will become anesthetized afterwards. But the pinch is going to be exactly the same. So does it make sense that you would actually give somebody an injection first that they're going to feel, and it's going to feel kind of weird, like a local, to then give another injection? You could do topical, but it's funny because I learned under, and I'll just, because I don't want to use names, I learned under somebody who would use local anesthetic. And then I started to question, it doesn't make sense, like why do this? So as soon as I started seeing my own patients, I just started to try doing it without. And I figure, okay, the first patient's gonna scream, they're gonna cry, and you do it, and they don't even, their eye doesn't even close. Okay, this is pretty easy. So we've had some debates about this, but there's a paper in here that actually was done in dermatology. It's really interesting, so we'll get to that. Depending on, this guideline is really not evidence-based. The 0.1 to 0.2 to a 40, so we're talking, 5 to 10, 4 to 8 milligrams for square cm ulceration. But some people may argue 2 to 3 milligrams would be sufficient. Some people would say, oh no, I want to go all the way to 12 to 16 milligrams. There's a lot of, and my approach could be different based on if I'm putting out the big fire or now the fire is smaller and I'm just trying to work around the edges. So my dose may change also, and I try and make a judgment, but there's no absolute algorithm to follow. The injection is, as you can see, it's not in the ulcer. You want to deliver it beneath the ulcer. So you enter the tissue somewhere just away from the ulceration, so the needle is actually sitting under the ulcer bed. And then, a lot of my residents like to take their time, and it's a slow injection like this. I go, and I'm done. Because patients don't, again, unless it's like the hard palate. And sometimes, especially, not so much with lichen planus for some reason, but with chronic graft-versus-host disease, ulcers of the hard palate are fairly common, and they can respond really well to intralesional. But if you're giving someone an injection in the hard palate and you try and give it really fast, they'll scream, I'm sure, because it'll be painful. You have to give it slowly, and even then, you'll get blanching, not because there's any vasoconstrictor, but just because the fluid is actually pushing the blood out. If we're treating lips, I always treat inside. There's no reason to punch through the vermilion. Your target's exactly the same. And that is going to be uncomfortable for the patient to break through vermilion. And then, depending on the condition, we may see the patient weekly, every 2 weeks, maybe monthly. Some patients may need a long-term maintenance depending on the condition. Again, it's a little bit touch and feel. But it would be rare that I would give more than 2 to 3 weekly injections. We usually like to space out more than that, and but again, depending on the diagnosis, the clinical situation, there's really a lot of variability. Procedure is very simple. So we have the vial, the ampule. Draw out the amount that we want, get out any air bubbles, and then at least the syringes we use, they're marked really along one side. So I always want to make sure, and you can turn it, you can adjust it, but I always want to have it so I can see. It's not so important if I'm only delivering to one area, but oftentimes I'm drawing up a larger amount and I'm treating several areas. And so I have a plan and I want to execute the plan. So maybe I'm going 0.3, 0.3, 0.4. And I just want to boom, 0.3, okay, 0.3, and I have 0.4 left. But you can't do it if you can't see the gradations. And then this is one of my former residents. You can see just very simple, with a nice positioning. I wasn't even planning on taking a picture of her that day, but I was having her do the treatment, and her form was so perfect that I said, do either of you mind if I take a picture right now? She said, no, that's fine. So I like the picture. And then this is another one, a different resident, our chief resident right now, injecting the tongue. And again, you can see very nice technique, just holding the patient very calm, didn't feel anything, great patient. So this was the paper that I referenced. Title of this paper, and published only in 2022. So this paper was published not right around the time that I was actually preparing this presentation for Indonesia. So intralesional corticosteroid injections are less painful without local anesthetic. A double-blind randomized controlled trial. I couldn't believe it when I found this paper, because I'd had this argument with my colleague for years. I've had this discussion, and sure, one paper is one paper, but they did the study, and these were for skin, not for mouth. But I don't see why it would be any different. And they simply diluted it with saline or diluted with lidocaine, and they treated 18 injections with saline, 13 injections with lidocaine with epinephrine. And you look at the post-injection visual analog scale pain scores, and for the saline it's 2, and for with lido with epinephrine it's 5. So. And interestingly, they note, while routine pre-treatment with topical anesthetic is reasonable and likely effective, it does increase the cost and time associated with the procedure. And I really like clean, practical papers where people write well and give important thoughts, because this is exactly what I've said to my trainees year over year. I don't focus so much on cost, because I have no idea how much our topical anesthetic is, but I think it's very inexpensive. But it takes time. So if I'm going to give a topical anesthetic before I do my steroid injection, just the fact that it's something that I'm going to provide has now created the opportunity for a question, like, oh, this must be painful. Oh, thank you that you're going to use topical. That's really nice of you. It's just time. Even if it makes you seem like a better doctor, I don't care, because it's not necessary. So when I'm working with a resident and they get everything set up, and then I see them getting the topical out, if I can do it in a way that doesn't bring attention, I try and stop, because it just adds it's just extra for no reason, because it's not necessary. Okay, what about side effects and safety considerations? So I would argue, for the most part, this is a very, very safe treatment. But no treatment that we provide comes without risks. So first, potentially some pain. I don't think that this is really much of a consideration, but there are situations that can be painful, and potentially in injecting the lips in a patient with orofacial granulomatosis may be a situation in which a topical anesthetic may be indicated, and I'll show you a paper about that. In the skin, ulceration has been reported. I have not seen anything reported. Again, the literature, even for the skin, is really, really small. When you talk about the oral medicine, oral mucosa literature, it's really small. And we're talking over, I'll show you the first papers going to the 1960s, but really in 60 years, there's probably 25 papers or something. I mean, it's incredibly, incredibly small. I haven't seen in our practice or anything in the literature ulcers forming from the injection. Atrophy, like with steroids, has been reported in the skin. I think it's something we can see in the mouth if we inject an area frequently over an extended period of time, but it's not common, and I'm not sure that it matters, but it's something we can see. Pigment change is noted in the skin. I haven't seen that in the mouth. Calcification has been reported. We have not seen that or knowingly seen that in the mouth. And then a localized allergic reaction, which we've seen once, and I'm not exactly sure what was going on, because it was a really complicated situation in a patient with acute graft-versus-host disease on a number of different treatments, but who had really, really bad mouth disease. and after the steroid injection, he developed really profound facial swelling. Probably some sort of localized reaction. It's the only time I've ever seen it happen. Systemically, and I'll show you some reports of this, the HPA axis can be suppressed. So patients can actually develop like being on systemic steroids. You can see endocrine changes. Patients can develop hyperglycemia. In children, there can be growth inhibition, and patients can develop systemic allergy. So all these things have been reported, but they're not frequent. So this was, so here's a paper, again, 1962. So not very long after clinicians were starting to use injectable steroids. This paper, reactions following intralesional and sublesional injections of corticosteroids. And I love when people write in a very honest way. So this is, again, less than 10 years from that first paper that I pointed to. And they say, although local injection of corticosteroids has been used for 10 years and has been used extensively by many dermatologists, still too little is known of the corticosteroid which is preferred in regard to its chemical composition, its solubility, and its concentration. More data is needed, as indicated previously, on the basic cellular action of the local corticosteroid mass. So he's basically saying, I'm talking about reactions that we've observed. We've been using this for 10 years. But honestly, we don't really know if this is the best way to do it, if there's a better formulation, what is actually happening. But at least I'm going to describe some of the problems that we've encountered. And then here's a couple more papers. So this one from 1988 is describing a systemic response to intralesional steroid therapy. Patient had, almost like sort of immediate physiologic reactions after receiving the injection. Another paper describing hyperglycemia in a diabetic following intralesional steroid therapy in a type 1 diabetic. It's a patient who developed clinical anaphylaxis, thought to be related to the triamcinolone acidinide, and they did subsequent allergy testing and found a really high inflammation response to triamcinolone, confirming that was the cause. Very interesting that a steroid would actually cause anaphylaxis in somebody. But again, you're going to give this treatment some days. Patient says, what's the worst thing that can happen to me? If you really want to know the worst thing, there are reports of anaphylaxis. I don't think it's common. If something happens, just like anything else, and we're going to do it. And obviously, patients, in my situation, patients in the hospital when I'm doing a treatment, so the emergency room is not very far away, versus somebody else who's in practice in the city. Here's another report, patient developing Cushing syndrome after intra-articular, so in this case in the joint and skin, so different conditions in 3 pediatric patients. So this, consideration like with topical treatment, maybe depending on age and size and body mass, some things that are safer in some situations may not be as safe in other situations. I use intralesional in children all the time. But again, you have to be aware that something could happen. And then this is really interesting, and this is, I think, the only description in the literature. This is from colleague Michele Mignogna from Naples, Italy, and describing, this is in another paper we'll get to, where he describes using sort of ancillary intralesional steroid therapy in patients with pemphigus, still requiring systemic treatment, but then treating like the hot spots, so to speak, with intralesional, but developing these, what were called these sort of yellowish, it's either like a fat deposition or some sort of collection from the injection. We're not really entirely sure. These usually, it's not common, but I've had this develop in some patients, and usually with time it just dissipates. It's not painful, but it can be very notable. So that's sort of the basics. And now we'll talk a little bit about skin and then finish with the mouth. So these are some really, again, I think really cool literature. This is from 1963. So this is only a year from the other paper we just read, which talked about, you know, sort of, we're figuring things out. We're sort of, you know, a lot of people are treating, but we have a lot to learn. But then you see that there's some groups doing some really interesting work, and there's nothing like this in the mouth in the oral medicine literature. So this is from 1963, looking at, you see the effects of different concentrations on psoriasis lesions. And so they actually used different concentrations and treated like one part versus the other part, and then looked to see how they reacted to determine what the most optimal concentration might be. Another paper, much more recent. So this is just from 2022. And now they're comparing, again, going back to that comment from the 1962 paper, like which is better. So it you know, in this case, it took somebody, you know, like many decades to say, well, let's do the study and determine. So they looked at intralesional betamethasone versus intralesional triamcinolone in treating patients with localized alopecia areata, and basically found they both work, but triamcinolone works better, works faster. But again, it's a really cool study design, right? Really clear, really obvious what they were doing and why. This one I find interesting for a few reasons, but because this is a condition, obviously, that we can treat in the mouth. And a couple of interesting references, but this is a case that actually, as you can see if you read carefully, ultimately, they treated this pyogenic granuloma lesion on the skin with several injections, and eventually still had to do a very minor surgical procedure, but much more superficial than they would have otherwise. And interestingly, they say this report is the first successful therapy of pyogenic granuloma by local injection of steroid, suggesting that this therapeutic strategy may be one of the effective treatment alternatives for pyogenic granuloma. And note the year 2009. So another report from the skin literature, in this case, eosinophilic granuloma of the skin, also something we might encounter in the mouth. Histiocytosis disease, again, really, really effective treatment just with localized injection. I have to imagine that this is painful. I fortunately will never inject somebody in their nails, or hopefully never have to be injected in my nails. But in this case, intralesional triamcinolone injections for nail dystrophy with, as you can see, really remarkable results. Again, just this intensive localized treatment, probably more effective than anything else they could possibly offer for the patient. This is really interesting, and I've had a patient recently that is actually receiving this treatment. Patients who have lichen planus affecting the esophagus, not very common, but it can happen, just like graft-versus disease can affect the esophagus. And it can form really, really painful, tight stricture with a lot of inflammation. So you can see, I mean, it's not just the ulceration, but like all of that stenosis, stricturing, and just with intralesional steroid therapy, and how exactly it's delivered, I'm not sure. Amazing, amazing results. It's just incredible. Intralesional steroid therapy of pyoderma gangrenosum, so in patients with ulcerative colitis with skin involvement, demonstrating efficacy. Another paper describing intralesional steroid treatment in management of cutaneous aspects of Crohn's disease. And, you know, I include these papers as essentially representative papers. So if any of you want to go and try and dig deeper into the literature, there must be 10, 15, 20 papers describing these situations. They don't exist. So there's no big, large case series even of patients with inflammatory bowel disease. It's all these just like small individual reports, which is pretty remarkable. A really interesting one here for a number of reasons. I'll read this out loud, but this is with Crohn's disease affecting the vulva, which I would say is from a tissue standpoint very similar to treating the mouth. And this is a great letter, 1992, the Journal of the Royal Society of Medicine. They say a letter was published in a previous journal edition, so 1991, maybe that was end of 1991, now this is early 1992 that the response is being published. They say this letter suggests that if medical therapy fails for Crohn's disease of the vulva, so whatever systemic treatment, steroids, whatever they're receiving, that vulvectomy or debridement therapy may be required. I suggest before resorting to surgery, try local injection of triamcinolone as a suspension into the vulval areas, both intradermally and below any ulcerated areas. I discussed this in 1985 at my presidential address to the section of coloproctology, and I use this technique for perianal, peristomal Crohn's disease and pyodermal gangrenosum. I have only seen one mild Crohn's disease involvement of the vulva, which did not require this therapy, but I would very strongly recommend that it be tried before radical surgery. Another paper from the dermatology literature describing the effectiveness of using intralesional steroid therapy on the scalp in patients with pemphigus. Again, they're on systemic treatment, but to limit their overall systemic treatment and/or for patients who have that disease, even the systemic treatment will not completely control it. This is a localized treatment that can be effective. And I think, for the purposes of time, I won't go through this slide in detail, but it's a nice slide from a paper from 1995 that talks about different fields of medicine and the different conditions and indications in which intralesional steroid therapy might be considered. Like the way I started the lecture talking about the different oral conditions that we would consider. And so in the last few minutes, we'll talk about some of the oral medicine literature. This is the only sort of comprehensive summary paper out there describing intralesional steroid therapy in oral medicine. It's a paper we published a few years ago. I think some aspects of it could probably be a little bit more clear in sort of what we're explaining. But actually, I'm just embarking on a focused paper on graft versus host disease, because I think we can tell that story in a really nice, detailed way. And maybe we'll do that for some of the other conditions subsequently. But for any of you who are interested and/or haven't read, I suggest reading this. It talks about all the different diagnoses and conditions that we primarily are focusing on, plus others where, again, sometimes we use a treatment in a situation where we sort of like, well, what are our options? We know this is inflammatory. Let's see if this helps. So for oral medicine, we go to 1966. This is the first report that I'm aware of that describes use of intralesional steroid treatment for an oral condition, in this case, oral lichen planus. This was published out of Ireland, 1966, and describing that in these patients that they're describing, that this one patient received intralesional steroid therapy and had phenomenal response. 1 year later is this report from brief Yale report, the Yale Journal of Biological Medicine. And this is much more descriptive, really interesting. They say each lesion was given a dose of 0.5. This is 10, so 10 milligrams per ml, so 5 milligrams, reasonable amount. This is non-ulcerative lichen planus, just inflammatory, symptomatic. Gave it a few little fractions, says that in a larger lesion they gave a little bit more. They reported there was little to no discomfort following the injections. So again, if you were training somebody formally and you said we're going to review all the literature, you're going to learn about intralesional steroid therapy before you even think about treating a patient, and you read this paper from 1967, which I only read in 2021 or 2022 for the first time, you would see that the earliest person, the second earliest person who had experience with this actually wrote in their paper, it's not painful. So if you read, there's a lot you can learn because you won't find that anywhere else. If you Google intralesional steroid therapy, it's not going to take you to the 1967 paper and be like, oh, good for lichen planus, not painful. You're never going to find this. And then, I highlight this. This is obviously, nearly 10 years later, but this is a series of patients being treated with intralesional steroid therapy for lichen planus in the mouth, being reported in Lancet. So, it's taken a step forward, and I think that's really cool. And then, truly, this is probably, when I was in training, this was probably the best reference that I knew about, that not only was a great reference at the time for lichen planus, because it held its own for a good 10 years, I would say. I was in dental school from 1996 to 2000, so this was a relatively recent paper from Critical Reviews of Oral Biology and Medicine, and this was a really, really thorough paper at the time, as up to date as could be. And he had a section in this paper talking about intralesional steroid therapy, and it's incredibly well referenced as well to what was available, even at the time in 1993. So this is also helpful in finding some of the early literature. Again, if you're interested, interesting reading. This was a paper describing management of major aphthous ulcers in patients with advanced AIDS. So, we have I don't have time to get into it. We'll save it for another discussion. But, these could be, at the time, especially before there was very effective treatments for HIV disease, patients with advanced AIDS, it was not uncommon for patients to develop really severe aphthous ulcers, like major aphthous ulcers that would oftentimes last for weeks, months. Fortunately, not something that I saw very much of ever in my training or subsequently, just because the nature of the disease has changed so much. But I've had a few patients with this condition, and intralesional steroid therapy can be very effective and was reported in this paper. And then here's a more up-to-date review paper on recurrent aphthous stomatitis by a couple of my colleagues at University of Pennsylvania, and they mentioned to consider intralesional steroid therapy. The first report of describing intralesional steroid therapy for treating orofacial granulomatosis or colitis granulomatosa is from 1965, and subsequently in 1971 is the first report in the oral medicine literature, specifically at the time the O journal, and they report something pretty similar, that you can inject this condition and the inflammation can significantly regress. This was a study, this study from 1993 described giving nerve blocks first and then giving the injections for injecting the lips in situations where patients find that it's so painful to inject the lips otherwise. I think in some cases the lips are swollen enough, there's enough inflammation, it can be painful. This still seems like more trouble than is necessary to me, but I also am not the patient. I would rather just deal with some pain and be done with it than have my whole face feel like numb and in paresthesia for the next 3 or 4 hours. This is a really nice study from Dr. Mignogna and colleagues. This is with Dr. Fedeli, for those of you who know Stefano Fedeli, when he was still training, living, working in Italy. And it's a very nice paper in that the protocol is very clearly described. They even mark, they show you where they've given the injections, and they have a, I would say, a clinical protocol that they follow. So, one person doesn't do an injection here and there, and the other one does here and here. It's like, no, we do this amount, we do it this way, and found that you really don't need to give very much for it to be effective, but they would distribute it nicely. So, and they give numbers. So again, some of like how we base our treatment guidance is based on what others have reported, and then you just build from there. And they talk about if it was unilateral versus bilateral swelling. And then some of the same authors subsequently in 2014 reported not just the effectiveness, but sort of the long-term effectiveness, I think, which is really important. So the fact that you can give this treatment over time on whatever type of basis to actually keep a condition controlled, because over time it will stop being effective, just like the patients I talked about that I might treat every 3 to 4 months with lichen planus. It's not going to be effective forever. Here was a report, again, from my colleague, Dr. Mignogna in Naples, describing, a single case of a patient with oral involvement of Crohn's disease, so ulcerative orofacial granulomatosis, essentially, being treated with intralesional steroid therapy effectively. And then I really like this paper, because this is a pyogenic granuloma, same diagnosis as the pyogenic granuloma of the finger that we saw earlier, reported as a case report in oral diseases. They say as an alternative to another surgical procedure, lesion was injected with intralesional corticosteroids. They diluted with bupivacaine, so again, they used an anesthetic, it's fine. They talk about how much they gave. They gave it over a certain period of time, over a period of 9 weeks. They kept seeing improvement. And they say there have been no reported cases of treating pyogenic granulomas with intralesional corticosteroids. The paper from 2009 said the same thing. But the dermatologist in 2009 didn't look at the oral medicine literature. And then, again, for my colleague, Michele, reporting the use of adjuvant triamcinolone acetonide in patients with pemphigus vulgaris. So they had its retrospective, and every retrospective study has its potential shortcomings. But what they show here is that the patients who received intralesional steroid therapy had resolution faster than those who did not. Another interesting report of patients with lichen sclerosis of the oral mucosa. I've only seen one patient in my career to date. Matt, how many patients have you seen? None? Yeah, I've had one so far. It's not common, but it typically affects the vulva or vaginal mucosa. And in 1 or 2 of these, they use intralesional effectively. So again, it's been reported here. And then I just highlight here, this was a paper we published in 2008, sort of early on, when there was a lot of interesting things to publish about medication jaw osteonecrosis. And we thought it was really important in describing these very painful tongue ulcers that patients were developing, because it's really a separate diagnosis from the osteonecrosis. The osteonecrosis is a problem on the lingual myelohyoid ridge. And yet these patients are developing, in some cases, some of the worst traumatic ulcers we've ever seen. So in 2 of the cases, part of our treatment was intralesional steroid therapy, and I'm just happy to know that we have it in the literature here. So that's just another reference. And then a few clinical cases, and then we'll wrap up. So these are both cases of patients with traumatic ulcerative granuloma lesions. And what I'd say is I don't necessarily biopsy initially in every case, but that's part of the benefit of having, in my case now, decades of experience in clinical practice, where based on a patient's history, based on the clinical features, I have a better or worse sense about what the diagnosis is. And I'm also never going to treat a patient with a lesion like this and not have them come back within a month. And if I think they need a biopsy at that point, maybe I've made a misdiagnosis and it's cancer, I'm not going to miss the diagnosis. But because these lesions can be incredibly creative in how they present themselves. But both of these, just intralesional steroid therapy, complete resolution. These are both, the upper is a patient with graft-versus-host disease with an area of these persistent, really painful refractory ulcers. We injected, completely cleared up. This is a patient with oral manifestation of Crohn's disease. Again, really painful, these fissured ulcers injected, closed up nicely. For those of you that will be at the rheumatology talk, you get to see this case again, because this is a patient with lupus, with involvement in the mouth, and would come to see me anytime they flare up. I inject. She might use some clobetasol afterwards, but clears entirely up. And they're really interesting cases, I think. These are both pyogenic granulomas, really big pyogenic granulomas with essentially complete responses with intralesional treatment. I think this is the last one. This is a patient I treated within the last year with orofacial granulomatosis, pediatric patient, again with phenomenal response to the injections. The hair color change was not a toxicity of the treatment.
It's not a side effect.
No. So I know we covered a lot of ground. Hour and 10 minutes. Hopefully everything worked on YouTube for everybody. Intralesional steroid therapy, I think, is, and hopefully not just because of what I said, but because of what you saw in the lecture today, is really an integral part of the practice of oral medicine. It's like anything. I know everybody loves to use a laser here. But you need a diagnosis. Hold on. You need a diagnosis, and just like intralesional steroid therapy, it doesn't work for everything. It's not the right treatment for everything. Sometimes it just won't work, even when it should work. So, you have to know what your options are. Case selection, treatment planning is really important. There may be a patient where they need intralesional steroid therapy, but their treatment plan needs to go from A to B to C to D to E. And it's at point C that they're probably maybe going to benefit from intralesional, but not here and not there. So, just thinking about it, recognize that even though it seems really simple and really safe, that there can be side effects. What can you do to minimize? What can you do to anticipate? And if it's not evident from plenty of things that I said today, there's huge opportunities for research here, but challenges also, because you only have so many patients. You can't necessarily treat everybody the exact same way. Some of the conditions we manage are not so sort of simple and long-standing, like, oh, we can just map out the top of the head and do this and this. But things to think about. So I'll stop there. I'm happy to answer questions, and I know we'll have a chance to talk about some of the literature later this afternoon. So thank you.
Let's open for questions. Please, guys, do you have any questions? I have. Go for it. Thank you so much for such a nice lecture. Since this is something that we don't used to do in our clinic.
Wait, is everyone going to stay on YouTube for the questions
Yes,
also?
yes,
so we
yes.
should, here,
Yes.
no, just use the microphone.
Yes, okay.
Thank you so much for such a nice lecture. It was a great opportunity to learn about this important therapeutic option. This is something that we don't usually do. Actually, I have never done.
and I think my colleagues haven't either. It's really nice to have this historical approach showing all the fields where it has been performed so far. And I would like to ask you, how do you decide the amount of the steroids you are going to inject?
So, experience.
Yeah, unfortunately, there's no like absolute algorithm. So you can go to the paper from 1967, the papers from the 80s, 90s, and based on those reports, work within what you know has worked. But there's a range. And that's why in that slide, I gave, you know, in the basics, it was like 0.1 to 0.2 per 1 cm. I think it's a fairly conservative sort of like middle of the road, but half that amount may be effective. And I'll admit that when I'm seeing somebody and it's like, so imagine I have a patient with chronic graft-versus-host disease, and I have 2 patients, patient 1, patient 2. They each have a 3-centimeter ulcer, and it's painful for both of them. But the first patient, I'm seeing them for the first time. Somebody else has been trying to manage them, not so effectively. They're getting frustrated. They haven't even necessarily gotten the best advice as far as, you know, maybe other aspects of their management. So they're sort of in like a tailspin, and they're losing weight, and maybe they're crying at the visit because it's just like, I can't believe how bad this is. And I just figure, you know,
Let's go for
I might be able to hit someone, like I don't box, I don't fight. Maybe I hit them just the right way and they're gonna go down. But if I really, really hit them hard, I know I'm gonna put them out. And so sometimes I take that approach, like let's just not take any chances, because if I give the right amount and they come back and they're not better, all I'm gonna say is, why didn't I give 1.5 times the amount? If I give 1.5 times the amount, they're probably not going to develop an allergic reaction. They're probably not going to become hyperglycemic. They're probably not going to end up in the hospital. Like, you know, so, but that's how I balance it. Versus patient 2, I've been managing them for 3 months, and they're on topical clobetasol solution. Their condition, they're 50% better, which we said is a benchmark for anything in medicine, right? They're 50% better. I've already done my job. They're like, this ulcer is still like, you know, I have to eat on the other side. So at that point, I give them an injection, but like, I'm probably not going to go to like put the fire out. Like, okay, let's just, you know, we'll do the injection. So I'm biased by the clinical situation. Really good question. But I think that those numbers, like that I included and that are in the papers are, you know, they're all reasonable. I think most of what's, and to be fair, most of what's reported in the literature, if you actually look at our paper and then subsequently, like, because we're going to do this analysis in chronic GVHD papers, I think our numbers will skew to the higher dosing. And sometimes I have to be honest, like let's say we're treating 4 lesions in the mouth, and it works out so that I can use the full 40, like kind of mathematically it works. You kind of round up, like maybe they only each need 0.2, and that takes me to 8, but I draw the whole thing and everything gets 0.25, I mean 2.5, so I'm giving this extra little amount, you know.
Okay, thank you so
Yeah.
much. Any questions from you guys? Can you help me think? Professor Laura, our colleague.
Thank you very much. I will help me finish. I'm concerned about the non-biopsy of granuloma, pyogenic granuloma. We know that very similar lesions like erythrogen cell granuloma and other, they all have the same clinical aspect,
Sure.
the same direction, and the same origin.
Yep.
So they respond to this kind you know if the other reactive lesions also respond to corticosteroids?
It's a good question. I don't know.
Very good. Because if respond, you
Yeah.
don't have the biopsy after.
Yeah.
And if it doesn't respond, you
But
Exactly.
if respond, it's
Exactly.
good for the patients too.
Yeah,
They may
Right.
respond.
that's a good point.
thank you.
Nat, you know that why we decided to ask you for this lecture? Because I saw that you gave this lecture previously, and for us, we are more focused on manage patients with topical corticosteroid or systemic. So for us, your lecture was amazing to think about the whole story and another possibilities, especially in some cases that you mentioned that we are treating these patients for several years, and sometimes we use topical, sometimes we use systemic, but sometimes you have this patient with that area that is not responding.
You're going to
And-
love using this.
I think that
Amazing.
for us, we stay talking, the
No,
professor.
I've told,
I'll be with you.
When I explain people about using intralesional treatment, like if someone said you can't use intralesional steroid therapy in your practice, again, not for every patient, and I see pain patients where I would never use it at all, but it's literally like I'd be practicing like this. Like, I'm still functional, but if you really told me I can't use it, I'm not going to be as good of a doctor anymore.
We have a question here from Natalia Laureano, your postdoc student. To complete Professor Fernanda questions, will the choice of injection treatment always be after testing the topical treatment?
No, I would, no. So for example, I showed you the traumatic ulcerative granuloma lesions, the two tongues with the big ulcers. I wouldn't start with topical treatment for those. There's no way it's going to work. No way topical treatment is going to work. Lichen planus, yeah, there's very few situations in a patient with lichen planus that I would not start with topical treatment. There might be a situation though, like I was talking about with patient one of those two patients with chronic graft-versus-host disease, where I'm going to start them on topical treatment, but at the first visit, I'm also going to give intralesional. So for like one or two problem areas, we're going to get the process started faster. Because when you give intralesional, I don't think I even mentioned this. When you give intralesional, it's not an immediate effect. It's not even, some of the papers talk about 48 to 72 hours starting to see response. I usually tell patients we're talking more like 1 to 2 weeks. Not even 3 days.
And when do
Some will report 3 days, it's starting to feel better, but not necessarily.
when you do the injection, when you decide that it's good, or you need to do a new injection? 2 weeks?
2 weeks, at least 2 weeks.
Okay.
Yeah, at least 2 weeks. Yeah, there's rare, really rare situations where you might consider something so bad that I want to see you in a week, but 2 weeks typically, and at 2 weeks usually more like a month.
Based in your lecture and all the reference that you sent to us, and we start to read more about this kind of method to use corticosteroids. I think that we really don't use so much here because we are not so familiar. We use more with oral granulomatosis, but we don't see so frequently this kind of lesions.
nobody does.
But with oral lichen planus or GVHD, for sure we must use more. And sometimes we are afraid with some systemic corticosteroids because some patients could have some side effects, but we usually use more post-therapy, so we don't have so many side effects.
Right.
But it's really nice to think about to use the injections, for sure. Thank you so much.
I promise you, it will be a total game changer for how you practice. Once you have experience with a few patients where it's the right thing at the right time, you'd be like, I can't believe I didn't do this before.
And we don't have a lot of side effects. You show that.
It's really rare, really rare. It can happen. Like I said, fortunately with that one patient, they were in the hospital, but they were such a complicated patient that I can't tell you like why did they have the reaction, but I've never seen it in another patient, and fortunately that patient was in the hospital. But I haven't had, I've had many more patients develop systemic steroid side effects from using topical steroids.
We too.
Like far, far, far more common. It's not common, but I mean, I have, if at some point we do a retrospective, I mean, I have many patients to report with significant, becoming like very full, developing, bruising.
We have the same experience with topical corticosteroids sometimes because patients still use it for a long time, and we have some patients with side effects too. Laura, do you have a question?
It's related to what you were saying.
Okay, no question? So, from what I understand, it's a local treatment, right? So, would you be concerned with the systemic effects? That's what you guys were discussing now. But if I have a patient with really high blood pressure, it's a diabetic, should I be concerned with this kind of treatment, like the systemic?
Can you answer your question?
I think I would, but
You said, should I?
yeah.
Is anyone going to tell you no, you shouldn't?
So would you? Is there like a
So,
type of patient that you wouldn't perform this kind of treatment?
so what are the ways that you can minimize the risk?
So I think you have to think about what are the ways to minimize the risk, right? So am I going to go for a really big dose for this patient, or am I going to maybe shy on the side of going lower than I normally do? That would be reasonable. Am I going to counsel the patient in advance? Make sure we're going to watch your blood sugar values really carefully over the next few weeks, see how it goes. And sometimes you have to give treatments that you know will cause some short-term problems, right? I mean, many cancer treatments are toxic, but if you don't go through the treatment, you don't treat the condition. Like in planus, you could just argue it doesn't need to be treated. People could live off of, milk and sludge or whatever you could eat and, be in pain, but you're still going to eat. I think the most important thing is where you started, which would be, your patient. I think the most reckless way to be treating somebody would be to not know their history. And many people may do that without thinking about it and then lead to a problem and be surprised that a problem occurred, versus I know my patient. We've actually had a frank discussion about this. We recognize that this should be a safe treatment. It's really uncommon for there to be side effects yet. This doctor that I just met, talked about a patient just like you who developed hyperglycemia and ended up in the hospital, so I don't want that to happen to you. So let's watch out. And maybe the patient says, you know what, I don't even want to take the chance. And then you don't talk about it any further. Or they say, this is killing me. Like, that's fine, I'm willing to take the chance. I've dealt with my blood sugar out of control before if it happens.
Good question.
Any question? Another thing that I would like to ask you to discuss a little bit more. At some point you mentioned that with this kind of treatment you can manage to keep patients without lesions for a longer period of time.
Say that again.
A longer period.
But what lesions with
For
something?
example, autoimmune lesions that are lichen planus. Sometimes we see that the patients respond really well to topical corticosteroids, but when you try to remove the treatment, the lesions recur.
Yeah.
And can you say that with this injection of steroids, can you keep the patients without lesions for a longer period of time?
Yeah, so I agree. If you use topical treatment, and assuming you're not getting a systemic effect from the topical treatment, I mean, within a matter of weeks, some patients it could be a day, one day,
Yeah.
right? I mean, if they go to once a day versus twice a day, they know the difference.
We try to
Right.
remove the treatment and
So-
conditions.
Right, so I think, for topical treatment, that's always part of the game, like getting somebody to the least that they need. Like I'll tell a patient, even go one rinse every other day.
Uh-huh.
If that holds it under control, like you can't just stop. With intralesional, I would say it can get you upwards of like 3 to 4 months. Now, I only have a few patients that I've treated this way because it's not that typical, but for somebody who either, like I said, just because of lifestyle or like physical capacity, it's really difficult to be able to do even a once a day, let alone multiple times a day topical regimen. Then it could be I think it's a really reasonable treatment. And and again, it needs to be the right selection. So like the patients I've treated, it's bilateral, posterior buccal mucosa, like the 1967 paper, just classic lichen planus. One target, done. You're not talking about oh well, it's the cheeks, it's the sides of the tongue, it's the top of the tongue, it's also on the roof of the mouth. I mean, at some point it seems almost like too much to be injecting all those places.
One more question from YouTube. Let me see. Bruna Song.
Does it say where they are?
Bruna is from here, but she's living in Germany.
Oh.
But she finished the PhD with me this year.
Okay.
We can definitely start applying this approach in the oral medicine clinics, but I say in Brazil may take some time to implement, especially in areas with limited access to specialized oral health care. What do you think? Is it cost effective for public service in comparison to other approaches?
I don't know. I mean, because I don't know what the costs are, and I don't know how the costs compare. I have to believe it's a very cost-effective treatment, but I don't know. It's something we deliver. We deliver it in the hospital or in the clinic. So I think that there's some efficiency there, just from the standpoint that there's no other pharmacy involved. But like to take your example, if I have one patient and it's going to require, let's say, a compounded medication, which is probably going to cost more than a non-compounded medication, and they need to use that, let's say, 3 times a day for 3 months continuously, and I don't know how you account for a patient's time, but that should be a cost per se. And maybe you could have the equivalent result at 3 months by just doing the injection. Go ahead 3 months in time, one cross-sectional visit, and you just ask the patient, 1 3-month period, it was clobetasol 3 times a day, 1 it was the injection. How are you doing? I'm doing great. It looks the same. I mean, it's not a simple cost analysis to do, but my guess would be, especially if you take into account patient time, patient preference, those types of things, that it would be like really simple. But my guess would be, even with the medications, it's probably still more cost effective. But then again, it's a procedure, so I bill for a procedure. I don't know what the insurance is paying for that. I don't know off the top of my head. So it's a good question.
I think here maybe it's different. I don't know if you agree with me, Laura, Marco, because here in the public service, sometimes, for example, clobetasol we don't have available. Only dexamethasone. If the patient will have to buy that clobetasol, it's very expensive.
Right, which I encounter also.
So maybe the injection.
Probably are gonna need to buy also nystatin.
And also nystatin, because we combine it, and nystatin for prevent candidiasis. So maybe if we have, and I think that we have in the public service
You can
available.
help. Yeah, you'll be able to help patients who wouldn't have access to something better.
Yes.
And even if you need to treat them,
a little bit more frequently and maybe a little bit more than like I would in my center, it could be a really reasonable treatment and something that certainly for the patient and their family be very cost effective and provide with better clinical outcome. Yeah.
Very good question. Any questions? No. So we have a discussion this afternoon at 3 p.m. in the room for, I think that 401B, I think. 401? 501B? 501 room. So come here in the front to take a picture with Professor Nathaniel, and thank you all, Matt, for your starting.
Good start.
We start with a very good lecture, and I think that this is the first one of several that we have ahead. Thank you so much for your generosity to share your knowledge with us. Let's take a picture, and thank you for the YouTube audience too.
Yep.